Welcome back. We are now going to understand about the acute lung injury and the acute respiratory distress syndrome. Okay, so acute lung injury. Now, as the name suggests, acute, it signifies abrupt in onset, and lung injury would lead to decline in its function and that would cause hypoxemia. Very important to know that it is in absence of the cardiac failure. Why? Because in absence of actually the cardiac failure would cause the pulmonary edema, okay, and hence we call it the non-cardiogenic pulmonary edema. Another thing to be aware of is that the ARDS is the severe form of the ALI. ALI in its most severe form, which is life-threatening, is ARDS. Now, the basic idea behind the etiology is inflammation. Whatever things cause the inflammation to the pulmonary parenchyma, that would cause the acute lung injury. Okay, so sepsis is the system-wide inflammation, and that would also not spare the pulmonary circuit. So sepsis would cause inflammation. Then we have pulmonary infection. Pulmonary infection also causes the like pneumonia, like the gastric aspiration pneumonia, that is the aspiration pneumonia, or the mycoplasma pneumonia, streptococcal pneumonia. All of these infections would actually lead to inflammation of the parenchyma. Right now we have the trauma to the lungs, that would be in case of the drowning when much of the fluid enters into the lungs, in the case of the burns, and when there is emboli, obviously that would be blocking some of the parenchyma and that would lead to inflammation. Then radiation can also cause the acute lung injury. Now the head injury and contusion are two different reasons of the trauma that also cause the acute lung injury. Then we have the chemicals or irritants. Obviously, the smoke is one of the most common reasons for the COPD, and also it's for the acute lung injury. Okay. Now the O2 therapy, the reactive oxygen species would cause damage to the pulmonary parenchyma. Then in OP poisoning and heroin consumption also, that leads to pulmonary damage, and that causes the acute lung injury. Now we have the transplantation associated lung injury, that is the TRALI, and then we have the pancreatitis can also present as the ALI. Now pancreatitis and uremia, it's established. We don't know the reason yet, but it's established. Okay, so keep that in back of your mind. Whenever we have the acute lung injury that is widespread in the whole lung, but we have unknown etiology, we call it as acute interstitial pneumonia. Okay, this presents usually as the respiratory distress or the failure in 3 weeks. Okay, now I have already established that the basic idea behind ALI is inflammation. And can we recall what happens in inflammation? In inflammation, we have endothelial activation, then we have the adhesion and extravasation of the neutrophils, followed by the increased vascular permeability and vasodilation. Then that afterwards we have resolution or repair. Okay, so same things are happening over here. Instead, the initiation is by pneumocytes. There is damage to the pneumocytes and to the pulmonary endothelium. Okay, and then we have the endothelial activation, then followed by adhesion and extravasation of the neutrophils. As you know, we have the capillaries over there. Okay, then we have the pulmonary edema. Obviously there would be edema because of the vasodilation and increased vascular permeability. Then there is something called hyaline membrane formation, and this is something that you need to be aware of. This thing is often seen in the acute respiratory distress syndrome, so it is similar to the ARDS. Okay, so why do we say that we have hyaline membrane formation? It's not that there is formation of the hyaline membrane. In the microscopic appearance, it looks like a glassy appearance, and that's why the folks have named them as hyaline membrane. Okay, now at last, obviously we would have resolution maybe in form of fibrosis or no, we don't know. Okay, it depends upon the nature or the course of the disease. Okay, now, obviously, as a result of the acute lung injury, we have the damage to the type 2 pneumocyte cells also. They actually die. And we know that surfactant is released by them, and that causes a defective surfactant. So that can be thought of as one of the reasons for the acute respiratory distress syndrome. The lack of surfactant is there, and that may be because of the type 2 pneumocytes injury. Okay, now the TGF beta and the platelet growth factor induce the fibroblast growth and the collagen deposition. Okay, In the gross appearance, the lungs would obviously be heavy, firm, red, and soggy. That's because they have so much of fluid of the inflammation inside them. Okay. Histologically, I think I've made it very clear that we have hyaline membrane in the ARDS. And pay attention, I'm not saying there is formation of the hyaline membrane. It only appears like a hyaline membrane because we have fibrin-rich edema fluid that looks like the glassy appearance. Okay. So this is the fibrin-rich edema fluid with necrotic debris appears as hyaline membrane in ALI. We also have something called diffuse alveolar damage. Diffuse in the sense that all the alveoli of the lungs are involved and they are damaged because we have lung injury and that is involving the whole lung. Now there is increased vascular permeability because of inflammation that leads to edema, and there is cell death, epithelial cell death, and the fibrin depositions as in the resolution. So all you can see guys, it's the sequelae actually of the inflammation. Okay, so the term you need to remember is DAD, diffuse alveolar damage. This is the slide for the acute lung injury. You can see clearly over here we have the hyaline membranes. We also have the fluid of the inflammation here. Okay, so clearly you can see the hyaline membrane. Once again, I'm going to clear the slide so that you can clearly see the hyaline membranes. Okay, clinically the patient would present with dyspnea and tachypnea. It's not hard to imagine that because there is hypoxemia. Then some patients may also present with cyanosis. In X-ray findings, we have bilateral pulmonary infiltrates that I've already mentioned. Then we have consolidation of the lung. The lungs are soggy. Recall they are filled with edema fluid, and that would lead to collapse also of the lungs. In the treatment, we have to clear the underlying pathology. Now, if say we have the sepsis, we need to clear it. If we have the trauma, we need to treat it. Then the patients may also be kept on the mechanical ventilation if required. With this guys, we are done with our understanding with the acute lung injury. Hope you guys liked it, and please share it. Please subscribe the channel. If you have any doubt, do put it in the comment sections below. Bye. See you in the next one.